All right. Hey, it's good to see everybody. I mean, not really see you, but virtually see you. And just want to say thank you in advance for your continued studies. I know that the start of this year has been a little bit weird. I also know that that is what, in general, we've been saying since 2020. What's the phrase? We're building the bike as we ride it, or we're building the airplane while we fly, or whatever. This is not that. This is just me taking the time that I need to be at home and be a good new dad. So, for me, it's a little bit different, but for all of you, especially students that have had me as a teacher before, know that, it's different not having me in the classroom. So I just want to start this video by saying thank you very much for being patient, and also for continuing with your studies, because I think that if you have had me as a teacher before, or if you've ever interacted with me outside of the classroom, you know that my goal is to make sure that all of my students are successful. And that's really the purpose of these videos. So as we continue going through this lecture series, please make sure that if you have questions or comments, leave them in the video. Go ahead and email me or DM me any questions that you might have that you don't feel comfortable putting on the video itself. And if you have any points of interest or things that I can do in the future to make these videos better, something that makes it better for you that I can incorporate, I absolutely will. So let's get started. Chapter 6 is anatomy and physiology. This chapter is dense. There is a lot of information. I know that other chapters in these lecture series seem like there's a lot of information, but this is critical, just absolutely bedrock information, the kind of thing that you build the foundation of your EMT career off of. So making sure that you are confident and capable with this information is really critical. So if at any point you feel like you don't get something, my best advice is to stop the video, go back to the point where you felt like you were lost, and listen to that part until it feels like it makes sense. Another excellent way for you to make sure that you're staying on top of it is to use these videos in conjunction with your textbook, with your PowerPoint notes, and with your handouts to make sure that everything that you're learning is making sense. And of course, on Canvas, there are supplemental videos. There are other resources outside of what I make. So please be sure to use those. But chapter 6, chapter 7, so anatomy and physiology, and chapter 7, which is pathophys, they're critical. So don't skimp on these, even if it's not your favorite thing, because understanding this will make you better prepared to work as an EMT. So really what we're looking at is body organs and structures. And specifically, we're looking at the body system. So the way that typically medicine works, or education within medicine, is that they go from the systemic approach, or they go from the organ focused approach. We use the systemic approach, or the body systems approach. So instead of talking about every single individual organ in the body in great detail, we spend less time in that realm. We do talk about each individual organ, but we spend more time talking about how they work as a singular system, and then how those organ systems, plural, work together. So if that makes sense to you, fantastic. If it doesn't, the easiest way for me to explain it is, instead of, let's use the analogy of a car, which we use a lot. Instead of explaining how every single part of the car works, we're going to explain how those parts work together. We're going to go in more detail talking about how, how the engine, operates as a whole, and then we're going to break it down into, smaller pieces. But we're not going to go as in depth as each and every single individual part. That would be way too in depth and would not make sense for this type of a course. So we'll start with body organs and structures. This is actually a very short section. The entirety of what we're going to be talking about is body systems. So when we're looking at body organs and structures, we need to be able to visualize them, and we need to be able to find them based on topography. So what this really references is your ability to recall what organs are where based on your ability to memorize where they're located. So when we talk in class, I tell you a lot that memorizing is not something that will get you an A in the class. What I really mean is you can't find a way to get a 100% on anything based on your ability to memorize. You have to be able to take information, remember it, and then apply it. So instead of rote memorization, rote being, a very educational term, so my apologies, but rote memorization is just look at a page, memorize everything there, and then regurgitate it back out. That's something that's very common in things, outside of science, and within science as well, but things like, history and different aspects of, the most basic science courses. But when you get into more in-depth science, or, my favorite subject, math, we look at information that we need to be able to understand, and then we need to be able to apply. So this is an applied science. So when we talk about visualizing, we need you to remember where the organs are located. And visualizing is difficult because most of these organs are going to be covered by your soft tissue. So we need to know what they look like in general, based on an artist rendering, or maybe even some real life pictures. And then we need to take that, make a photograph in our brain, and set it on top of the patient. And then we have topography. Topography is using the body's structure itself and using that to kind of, for lack of a better word, echolocate. Echolocate's definitely not the best word, but we're going to, almost feel around in the dark. I want you to take a moment and consider this. Every single one of us at some point has had to put our hand inside of a bag that we packed and locate something without seeing it. Now, if that sounds a little abstract, bear with me. If you have one right now, if you have a backpack in front of you, go ahead and reach inside a pocket that you packed, or one that you've gone into a lot. Now try to find something, and I want you to try to hold it in your hand without looking and say, I know what this is. Most of you can do that because you have stored in your brain what you've already put in there, whether it be because you packed it or because you've looked at it so much you just know where things are located. So by topography, in this case, we're looking at things based on where they're on our normal patient compared to other structures that really don't move. So an example of that would be using an existing structure like the rib cage. So using different aspects of the ribs or of the sternum to locate other aspects of organs that are located further inward or downward. So that would be one way that we could kind of understand that. Or if we want to go back to chapter 13, which I realize this is chapter 6, chapter 13 is vital signs, but we use topography to locate places to palpate a pulse, which we're going to talk about in this chapter anyway. So when we're trying to assess a radial pulse, we would go ahead and use topography to locate that pulse based on our recall of the radial artery being located just outside of the radius, the bone, and just on the inside of the wrist. So right up here. So that's what we're looking at when we're talking about locating body organs and structures. Now, quick little side note: some patients may have what we call abnormal organ placement or abnormal organ structure. This is rare. This certainly is not something that you'll encounter very often. And without really any exception, I've never had a patient that oops forgot until we got them under the microscope. I've had a patient that oops forgot that things were switched inside of the chest cavity when we were trying to look at his heart, which is a little bit weird, but for the most part, they're going to tell you, oh, hey, these things are switched around. But we'll talk about that more in another chapter. So don't get hung up on that. Most people, the vast majority of people, body organs and structures located in the same place. Now, we're moving on to body systems. When we talk about body systems, again, we're not talking about the individual organs. We're talking about how these organs work together as a system. So an example of a system would be the cardiovascular system or the musculoskeletal system. These are not just one organ, they're many organs or a few organs that work together. They have a primary job and they have to work together. So that's where body systems come together. So we'll start with the musculoskeletal system. Musculoskeletal meaning muscles and skeleton, and we're going to break this down into the most digestible version. The purpose of your musculoskeletal system is three-part. First, it gives your body its shape. Then it provides protection of our internals. And finally, it allows for our body movement. And I think that it is, kind of unfair to not mention here, but our unique anatomy, and by unique anatomy, I mean humans, gives us the ability to do things that other animals that are very nearly related to us that they can't do. So your musculoskeletal system is responsible for the way that we walk, the way that we ambulate, and the way that we interact with the world around us. So it's important that we understand that, you know, human anatomy is really what we have our focus on, and the musculoskeletal system is, you know, inherently something that we need to focus on for humans. The skeleton, we're going to break this down into easy digestible parts, and then we'll go more in depth. So this is your skull and spine, the ribs and sternum, your shoulders, upper extremities, the pelvis, and the lower extremities. So before we go any further, you're probably looking at that and saying, all right, trust me, it's all there. It really is. The skull and spine are differentiated from everything else because they are in, you know, a strange way, a system. The ribs and the sternum, again, are part of a very similar system. The shoulders and upper extremities are very dependent on one another. So again, a system. The pelvis and the lower extremities are similarly, you know, dependent on one another. Therefore, they are a subsystem. So let's break them down, and we'll go slowly through all of these. We'll start with the skull. The skull is going to be our cranium, what we understand to be that thing that gives our head shape and structure and protection. The primary function is to enclose and protect the brain, and it is something that we are able to see forming and shaping from the very earliest stages of lifespan development at birth. And you know, really, it doesn't find its final shape until, you know, years down the line. So our cranium is actually made up of different parts, of different plates, and they are ones that fuse together later on in life. And then we've got the bones that make up the face, which is the front of the skull. So if you're wondering, hey, how does all this come together? Well, over time, all these bones, you know, when we are born, they're not fused together. They're very loosely associated. Over time, calcification of those bones and those the fossa come together, and it creates one strong structure. So removing the lower jaw, that is going to be our skull. So feels like we're moving a little bit fast again. Stop the video, rewind. I'm so old. Go back and listen to it again. But we're going to start moving forward. So the cranium is what our brain needs to be protected by, but it's not just that. It gives us the function and the form of our faces. And if you think that that doesn't make a big difference, trust me. You know, I jokingly in class say, this is the moneymaker right here, but this is really what you present yourself with. And understanding that these bones are, you know, not just one, you don't just have one big face bone, they're individual bones and bone sets. We need to know what the names are. So the names, before we look at an actual, you know, an actual drawing, are the mandible, the maxillae, and some people say the maxilla, so maxillae, maxilla, the nasal bones, the orbits, and finally, the zygomatic arches. So again, that's the mandible, the maxillae, sometimes the maxilla, the nasal bones, the orbits, and the zygomatic arches. These are just words. They don't really help you unless you know what you're looking at. So we're going to spend a little bit more time looking on the next slide. So before we start looking at the cranium, let's look at those bones that we just talked about. So we'll start right here at the mandible. This is your jawbone, the mandible. And I'm going to go ahead and I'm going to use annotation. And we'll go ahead and we'll just kind of draw here so that we can make sure we're all on the same page. So this right here is the mandible. Okay. And really no reason to get more in depth than that at this level. So that is the mandible, the lower jaw. The next is going to be the upper part of your upper palate, your upper teeth, and you know, technically it's not your upper jaw. It's yeah, you could call it your upper jaw. We have the maxilla or maxillae. So this is going to be the maxilla right here. And actually, you know, as I look at that, I realize that that's a little bit confusing. So I'm going to use a different color. So this is the maxillae. This is the maxillae. The next bone that we had, let's go back real quick. We're not going to go back real quick. The next one that we're going to talk about is going to be the orbits. So the orbit is this bone right here, and I'm circling it in orange, that goes around the eye. And a lot of people say, orbit, why do they call it the orbit? Well, it's actually kind of unique. The structure of your eye is known as the globe. So that round thing that makes up your eye, that's the globe. The bone that floats around, or the bone that goes around it, is called the orbit, because anything that encircles a structure is known as an orbiting feature or orbiting object. Now, something that you might notice that is not here is the nose, because our nose, as a lot of people know, is a combination of soft cartilage and some more hardened cartilage. But really, right up here is the end of the skeletal structure. So if you think to any time that you've seen someone with a broken nose in real life, in movies, you typically see that line that's way high up. That's actually not, that's not anatomically incorrect, because that is where noses tend to break, is right there where the cartilage ends and the skeletal structure begins. And it's actually pretty easy to note because you can see that line. So that is why you don't see a nose here. It's because this is just skeletal structure. So we've got that, and there's our nasal bone. I'm not going to circle that. I think that that's pretty obvious just from where it is. And then we have, if we're moving on, our zygomatic bone. The zygomatic bone itself, we'll circle in green. This is the cheekbones, baby. This is the cheekbones. So if you're one of those people that has, I guess, good cheekbones, high cheekbones, or, you know, cheekbones that you like, that's going to be the zygomatic bone right there on both sides. Okay. Now I'm going to go ahead and I'm going to clear this. I'm going to clear this off, everything that we've just drawn. And I'm going to now focus on the aspects of the actual cranium. So what protects our brain? So our brain cover, our cranium, is broken up into a handful of different bones. Specifically, it's broken up for our purposes into 4 major bone structures, or as one of my instructors said, it's like continents. So think of these as land masses that have eventually come together. So we're actually going to start in a different spot. Instead of with the bones themselves, we're going to talk about where they meet and where they form up. And I'm going to go back to black here. And I'm going to underline the sutures. So if you look here, these structures that look kind of, you know, crazy and jaggedy like that, these are what are known as the sutures. These sutures form up over time. They're not there at birth, and they will, you know, eventually heal together so that we can have a solid skull. If it didn't happen like that, then, you know, you'd end up killing mom on the way out the door if it was a traditional or vaginal delivery. Now, if you're a C-section, if we're dealing with a C-section, that obviously is not important, but, you know, that's not the way that we've done it for, you know, all the, you know, centuries and millennia that came before us. So this is a physiologic feature that allows for safe and, you know, safe, reliable delivery of the baby without killing mom. Because if you kill mom, that kind of, you know, hurts your chances of extending the species lifespan. So moving away from the sutures, let's talk about the bones. The first one right here is the frontal bone. Frontal bone is going to be inclusive of a lot of these bony structures here, but really we'll go ahead and we'll just make an imaginary line right here, right about the forehead, and that's going to be the frontal bone. So the frontal bone goes from the area just above the eyebrows, and then breaks right about midway across the center, and sometimes a little bit more forward of the actual cranium. Now, the frontal bone is obviously very important. It's also one that is injured very frequently in EMS settings. So we're looking at things like car accidents, head-on collisions outside of a vehicle. That's a little bit confusing, so let me be more specific. So collision sports like football, rugby, this is where we get a lot of those injuries to the frontal bone. So we do get a lot of injuries that affect this area, so it's important to understand kind of where it is. The largest of these sections is known as the parietal. So right here, we're looking at the parietal bone, and you can see that it is inclusive of, and this is a very rough drawing, all this, and then you're going to have to imagine it on the other side as well. The parietal bone is by far the largest, and this is going to be from about the center of the top of the head. It goes all the way back until about the point where you would end up having a hat kind of sit. So that's going to be the parietal bone. So real big area, real big bony mass. And again, just like our frontal bone, this is not going to be sutured in place at birth. This is where we're going to be looking at the foramen, the anterior foramen, the opening that is at birth. So right up there at the very top. So if you've ever been told by a parent, you know, like myself, hey, don't touch the soft fleshy spot on the top of the kid's head, now you know why. We're going to continue, instead of going in the direction we've gone in, we're going to go to another easily identified area, the temporal bone. The temporal bone is going to be right where, well, you guessed it, the temples are. So this is going to be above the ear, and it's going to be more of a soft, fleshy feeling area, but that's not necessarily, you know, representative of the bone that's there. There's just a lot more tissue in between the bone than you would find in the parietal or frontal areas. So there is a bone there. It's just a little bit buried. So now that we know where that is, the temporal bone, and again, that's easy to remember because temporal, easy. We'll finish up with the occipital bone. This is by far the one that people struggle with saying the most, so I want to make sure that we're clear here. This is the very back of the head, and this is where the cranium ends, and we really have kind of the beginning of what you can feel in the back of the neck of your vertebral column. Now, this word here, occipital, O-C-C-I-P-I-T-A-L, occipital, it's a tough one. I want you to go ahead and say that real quick. Occipital, occipital. The occipital bone is located right there in the very back. We get this in a lot of the slip and fall cases that we get, or you know, rapid loss of consciousness or sudden loss of consciousness, where someone goes down like a felled tree and they fall right back on the back of their head. Now, occipital bone is certainly an area that is, you know, structurally sound, but we tend to see a lot of very, very obvious injury in the form of hematomas or very large bruising under the skin because of involvement of some larger blood vessels. So the occipital bone, and sometimes we refer to this area as the occiput, the O-C-C-I-P-U-T, occiput in our radio reports. So just know that if you ever hear that the patient had an injury to the occiput, we're talking about the occipital bone. That one's a little bit unique. We don't say we don't use anything else for the parietal, temporal, or frontal bones. It's just a little bit different, so I want to make sure that I mentioned it here. Now, there is one bone that we don't really talk about very much, but I want to make sure that we know. If you go a little bit forward of the temple area, we have the sphenoid bone. So the sphenoid bone you can trace by looking right here at your at the zygomatic bone, and then go up, and you can find that that sphenoid bone. And again, that's going to be very difficult to locate because of that soft fleshy area. But the aspects of the cranium that you do need to know for testing are the frontal, parietal, temporal, and occipital. And it may not be a bad idea to remind yourself of the sphenoid bone, but truthfully, I very rarely, if ever, see that come up in testing. So just so everyone's really clear, that's not one that I would expect to see come up. All right, we'll go ahead and close out the annotation tools. Again, if I'm going too fast, please go back and rewatch this section. Moving forward into the spinal column. Our spinal column is broken up of 33 vertebrae, and these are the unique individual bones that make up our spine. And their primary job is to protect the spinal cord. Your spinal cord is what delivers messages that emanate from the brain. So they start up here in the brain and then are sent out to the rest of the body. Your brain, it is regularly referred to as the computer that controls, you know, everything that your body does. But computers are only as good as the signals that they can send out and that they can use to, you know, interface with other things around them. The spinal column is how they interface. So think about your computer right now. You're obviously connected to the internet. How much of your computer could you functionally use if you didn't have an internet connection? And before anybody goes, well, Johnson, I've got Minecraft downloaded to my computer. Great, that's awesome. But think about how many things on your computer simply would not work if you didn't have internet. If you've ever traveled or, you know, been to an area that doesn't have, you know, reliable Wi-Fi, you know exactly what I'm talking about. So the computer will only be as good as its ability to interface with the world around it. Our computer has the internet, our brain has the spinal cord. So this is essential. And it's not just for movement or sensation. It can control things that, can, if interrupted, kill us, like our ability to breathe. And we'll get more into that in a different chapter, but, very simply put, part of our spinal cord is responsible for how we breathe, or at least for the part of the brain that says, hey, breathe, dummy, breathe, breathe, breathe. Because I know that there isn't a single person in class that sits there every day, 12 to 20 times per minute going, all right, breathe in, breathe out, breathe in, breathe out. So that's important to protect. As we move away from the column, I want to talk about the structure that most of us are very familiar with, especially if you've ever played any sports. It's going to be your thorax. Now, the thorax, don't get it confused with the thorax. That's Dr. Seuss. This is Mr. Johnson. The thorax is our ribs and our sternum. So I'm kind of pointing at my chest right now. The ribs that all connect to the spinal column and emanate off of there, and then connect to the sternum. Now, not every single rib that we have is going to be interfaced here, and we'll go into a little bit more detail in class because this is something that is harder to explain over a computer. That's why we have the skeletons and the models in class. But these ribs and the sternum are just, they're operating the same way as your spinal cord or as your cranium. They're primarily to protect the heart, the lungs, and the major blood vessels that keep us alive. They have other structure too, or they have other function too. They create the structure that makes up our unique human form, and they also allow for the function of the heart and the lungs to do their deal, but their primary job is protection. So you can see here this terrifying looking picture, the individual bones that make up the spinal cord. So if you look here, this is our skull. We've already talked about that, skull, cranium. This is our vertebrae, and you can see how it is concave and convex, and you've got this little kind of wiggly do right here. If you've ever thought to yourself, I wonder what my spinal cord looks like. Well, from the side view, so if we're looking at it from the mid-axillary view, so looking directly through the armpit here, you can see that it's got this curvature. Now, this is a typical spine. We're not seeing anything that would show deformity, but what's unique about this is, this is what gives us the ability to walk and move the way that we do. It's really important. Now, if we move and we shift this and spin it 45 degrees, 90 degrees, I don't even know. Sorry guys, it's late. If we spin this dude, we can look at it from the posterior view. And as we're looking at the posterior view, you can see where those ribs, generally connect to the spinal column. If you've ever heard the term floating ribs, they have to connect to something. They're not just floating and, they just show up one day when you get hit right in the very bottom of the rib cage. They're called floating because they don't connect to the sternum right here. So you can see how they're on this aspect here in T12, how they're kind of floating there. So if you've ever wondered why we have floating ribs, that's because all the rest of them wrap around to the front and they attach to the sternum. So the real focus here are going to be the four sections that make up, technically five, sorry, the five sections that make up our spinal cord, or our vertebral column. So the vertebral column is broken up into five sections. The first is the cervical. There are 7 cervical vertebrae, and this is at the base of the skull till about the point where our collarbone meets, or just above where our scapula kind of naturally sits. So we've got C1 through C7 down here. The next is the largest, the thoracic spine. The thoracic spine is right here. Again, we talk about having, everyone's about the same. We're looking at about the clavicular area on down to what we would consider the lower back as the thoracic spine. So we've got thoracic 12 vertebrae here. We call that T1 through T12. And finally we have, and I say finally because these are the ones that we're going to deal with the most, cervical, thoracic, and lumbar, and specifically cervical and lumbar. We have the lumbar section, which is our lower back. The lumbar section is divided up of 5 individual vertebrae, and we refer to this as L1 through L5. If you've ever wondered why there is a weird bar that pops out in the driver's seat of your car, or maybe your parents' car, or whoever car you're driving, and you're like, oh man, what is that thing called in the back? It's called lumbar support. People that have had lumbar injuries typically need to have something that's pressing up against them, up against their lumbar spine to relieve some pain or discomfort. And it's pretty much considered a standard feature on vehicles as of today. The lumbar and cervical spine, so right back up here, cervical or C1 through C7, and the lumbar spine, L1 through L5, are the most commonly injured. That sure sounds like a test question. What part of the spinal column is the most injured, or which vertebrae are most commonly injured? Cervical and lumbar. Now we have two more sections, because I said there were 5, and I wasn't lying. We've got the last bits called the sacrum and the coccyx, or as I say in class, the sacrum and the coccyx, because that's a ridiculous word. That's like that one road on the way out to Las Vegas called Zizix Road, where it's all just nonsense. Anyway, the sacrum and the coccyx are what we traditionally refer to as our tailbone. Now, these are different than these vertebrae. Something that we should mention here: each individual vertebrae from the cervical, thoracic, and lumbar spine are individual bones, and they can move independently, meaning that if we have pressure here somewhere in between L1 and T12 that's pushing in, they can move to a certain degree to allow for that motion to occur. These are individually spaced with discs made out of cartilage. That's something that we'll talk about in another chapter, but they are independent bones. The sacrum and coccyx, however, are not independent bones. These are fused vertebrae that make up our tailbone, and they are so well covered in our tissue that make up, the buttocks and other parts of adipose tissue that we won't really even be able to assess them effectively. The doctors at the hospital may need to do an assessment of the coccyx, and more often than not, they'll just use imaging because they're so well buried. But everything else here, C1 through C7, T1 through T12, and L1 through L5 are all, in theory, something that we can palpate, something that we can actually feel outside the body using our hands and our understanding of topographical location. Cool? All right, moving forward. Next, we have the pelvis. Now, I like to say that the pelvis is probably the hardest working bony structure system in your body, because if you really think about it, your upper body and your lower body basically compress it from, their respective sides. The lower body has all of that impact from the ground coming up through the legs into the pelvis. Your upper body rests, generally on the pelvis, whether it be, the soft tissue or the bony structure that makes up the vertebrae. So it's all got to sit there, and it's all got to make sure that it doesn't hurt you, that it doesn't fail. So these bones are incredibly dense. They are incredibly difficult to break, and in the event that they do break, it's not a laughing matter. I think that we've come to think of a broken hip as something that we associate with the elderly. It certainly is something that happens more with our elderly group, but I think that there's a lot of humor that goes along with, like, whatever. Thanks a lot, old man. Go break your hip or something. It's not as small as you might think. We've gotten really good at fixing it, but it truly is a life-threatening fracture, and one that needs to be seen in a hospital like immediately. So the pelvis is made up of these following bones, and this is a very basic set of bones. So please don't come at me and be like, "I took anatomy and physiology, and that's not all the bones." I get it. I know. I'm giving you the ones that you need to know as an EMT. So these bones are the ilium, the ischium, the pubis, and the hip joint. Now, the hip joint is going to be where we have the femur meet up with the pelvis at the acetabellum, and some people say it differently, but I just say acetabellum. So that's going to be that ball and socket joint that we all learned about back in 4th grade. Now, again, the ilium, the ischium, the pubis, and the hip joint, these are just words. What helps us? Well, drawings. And these are ones that you're not going to find in your version of the PowerPoint because I added them. This is something that I added because the original didn't have it, and I think it's really important to see. So here we have the ilium. You can see the ilium in pink. The ilium is in pink. So we've got the wings of our hips. Cool. And if you remember the sacrum and the coccyx, you remember where that sits? You see how that interfaces with the ilium? Again, our body really all relaxes right here on the pelvis. Then we have the ischium. The ischium is colored in blue. And this is going to be what makes up the structure of the bottom of the pelvis. And this is really going to be the front or anterior aspect of what our femur sits inside of. And then we have the pubic bones. Now, the pubic bones are something that I think most of us can find some way to remember. You know, there's, without getting, you know, crude or crass, I think that we can all figure out why it's called the pubic bone. But the pubic bone is going to be what makes up the more posterior aspect. And again, these are 3D structures, so it's not entirely correct to say it's only posterior, but this is what wraps around and creates that final loop where where the femur sits. Now, we talked about it earlier, the term, the acetabellum, you see right here where the ischium and the ilium kind of sit. And then we've got right inside here, this foramen. Foramen is basically just the entry point for another bone, so they can either sit or a space in between bones. So again, ilium in pink, ischium in blue, pubis in green, and then we have the acetabellum right here, and then the sacrum and coccyx back there. We've already talked about that's an aspect of our spinal column. Those are the fused bones, the fused vertebrae that make up parts 4 and 5 of those 5 aspects of the spinal vertebrae, the vertebral column. Now, as we move away from the pelvis, we need to talk about the bones that most of us are very familiar with, because these are the ones that we talk about a lot. So we're getting into bones that have a very specific, similar type of structure throughout the body. They're called long bones. A long bone, and I'm going to go ahead and I'm going to annotate here. So let me go ahead and throw some text up, make this box nice and big. Long bones are found in the extremities, period, full stop. They're found in the extremities. You have 6 of them. You have 6 of them. So we're going to start by talking about 3 of these 6 long bones that exist in the lower extremities. The first and most commonly referred to is the femur. This is what makes the bone that is the only structure that we see in the upper part of our lower extremity. So from our hip until above our knee, that is our femur. Very, very big, very hard to break. When it breaks, lots of bad news bears. Now the next bone, and if you're wondering like why I'm not throwing out random facts or whatever about femurs and these other bones, it's because we're going to talk about them more in the trauma chapters that we have coming up. The next bone that everybody seems to know about is the bone that makes up your kneecap or your patella. So that small, very, very unique bone is called the patella. That is not a long bone. That is actually known as a sesamoid bone. You don't need to know that for this class. I just wanted to throw that in there. But the patella is not a long bone. The only one that we talked about so far is the femur. As we go below the knee, we have 2 bones that make up our lower extremity, so the lower part of our leg. Those bones are the tibia and the fibula. Now, a lot of people have a hard time remembering where these are or which one we're talking about, so I'm going to make it easy for you. The tibia is the one that you can feel. You can actually feel that. Most people would say, oh yeah, that's my shin. Well, they're not wrong. The tibia is your shin, and this is the easiest way to remember it. If you go and walk through a dark room, you're probably going to end up whacking your shin on something. I always end up hitting my shin on the coffee table, so I like to call the tibia the table finder. Look at that, that's super easy. Tibia, table finder, to shin. And as an added bonus, it's the one that you can almost exclusively feel outside of the body, because it's not as well covered by muscle and other tissue as the other, the fibula. Now, the best way to remember this, if you are still having a hard time with the tibia one, is the fibula. That one's it's a little bit of a fibber bone. It's a tiny bone, and by fib I mean a line. The bone itself is still there. You're just not going to be able to feel it. All of the majority of the bone that you can feel, and I'm doing it right now, so if it looks like I'm moving around in my chair like a weirdo, I'm doing it because normally in class I would have my leg out so you could see what I was pointing at. But if you want, go ahead and put your hand on your lower leg below your knee and feel that, and you can feel your tibia. You can feel your fibula, but you might end up just going ahead and call it that fibbing bone. The fib bone, the one that you can't really feel, because, you know, with very, very limited exception, the fibula is going to be kind of buried. Also, the fibula is much smaller and, you know, much less dense than the tibia. So we have 3 long bones that we've already learned so far. We've already done half. Those are the femur, that's the upper part of the leg, the tibia, which is that really pronounced bone, that table finder, and the fibula, the one that's kind of fibbing. You think it's there, but you can't feel it as well as you might think. Those are our 3 lower extremity long bones. Moving further below those long bones, we have the ankle. Now, if you've ever heard medial and lateral malleolus, you can go ahead and look right at your ankle bones. Those little things that stick out to the side, the little knobs, those are your medial and lateral malleolus. And if you don't remember the difference between medial and lateral, medial sounds like median. Median sounds like, well, it starts with the letter M, sounds like middle, right? Medial line, right down the center. The lateral is going to be on the outside, which means that the medial malleolus is going to be on the inside of your ankles. The lateral malleolus is on the outside. And then, you know, we got all the bones that make up, the rest of your foot. So we've got the tarsal bones. Whoops. We'll go ahead and clear all these drawings here. Get out of here and move forward. We've got the tarsals, the metatarsals, and the phalanges. So in EMS, we don't ask you to memorize all the bones of the foot. And it's because at this level, as an ENT, that would be a waste of your time, especially when you consider the fact that we don't have the ability to really confirm what we're feeling in the field. It doesn't really matter if we know what part or what bone is broken in the foot. If we look at it and say, hey, there's a decent chance that that could be broken based on the fact that it's extremely painful, there's swelling that's present, there's a deformity that's present, that's going to have to go to the hospital anyway. And I don't want to sound like I'm being flippant and blowing it off, but we have to be wise with the amount of time that we spend learning so that we don't waste any of that brain space or time on things that we can't functionally use. But it is important to remember that we have the tarsals. That's going to be right there in your heel. The metatarsals are going to be kind of the middle. And then finally, you have the phalanges that make up the toe bones. So those are those bones that make up your toes. Phalanges. And we got phalanges elsewhere, but we'll talk about that in a minute. The bone that makes up your heel is known as the calcaneus. So now that we've talked about all that, again, if it's going too fast, go back, rewatch, and move forward. And if it seems like there's a helpful guide coming up on this one, there isn't, because the ones that I really, really need you to know are the femur, the tibia, the fibula, and honestly, the phalanges, those toes. Oops. I'm not going to stick my foot up and wiggle my toes. I don't think I can do that, but you get the idea. The upper extremities. The upper extremities are going to be what makes up, our arms, but it doesn't just sit there the same way that our lower extremities do, because our lower extremities really begin at the femur. Our upper extremities include the clavicle and the scapula. The clavicle is your collarbone. Clavicle, collarbone, clavicle, started to see, super easy to remember. The scapula, the one that sits in the back, that's your shoulder blade. I always remember that. I think of scapula, spatula's flat. The scapula is a pretty flat bone too. So if we're looking here, and we can all feel on ourselves, don't reach over and start putting your fingers all over your partner's bones. That's a good way to get expelled. You got the clavicle right here, and in the back we got the scapula, which is the shoulder blade, scapula, spatula. Cool? And clavicle, collarbone. The next aspect, and I'm trying to go in anatomic order from top to bottom, is the acromion process. Now, the acromioclavicular joint is where our humerus, where the humerus kind of sits inside of this joint up here and allows for rotational movement and allows for you to articulate the bones. Honestly, the acromion process and the acromioclavicular joint are not things that you need to commit to memory, but it is something that I want you, for my class, to at least be familiar with. What I do want you to focus on and what you will be tested on are the last 3 of our 6 long bones. So again, I'm going to go ahead and grab annotate, throw a text box up in here, do some text business. We've got how many long bones? How many long bones? 6. 6 long bones. We already did the first three: femur, tibia, and fibula. These are the last three. If you really think about it, our upper and lower extremities are kind of similar. The upper part of our upper extremity is the humerus. That's a big, dense, heavy bone that is kind of singular on its own. It's doing its own dang thing. Okay, so the humerus right up here, that's that one singular bone. What does that kind of articulate to in the lower extremities? The femur. The femur and the humerus are in the same spot. They are in that upper aspect of their respective extremity. Now, if we move down past the humerus, we have two bones, the radius and the ulna. And we have a similar structure. And by that, I mean, one bone is much larger, much more dense than the other, but it's not necessarily as point and click as we did with the lower extremities with the tibia and the fibula. So with the radius is actually pretty easy to remember. And if you've already watched the chapter 13 lecture for vital signs, you already know what I'm going to do. This bone right here that runs along your thumb. So if you're holding your arm out like this and you're tracing it right here, that's your radius. And the radius is rad. Radius is rad. It's super easy to remember. I'm a nerd. I don't care. The other side is the ulna. I'll be honest. I don't have a good one for that. The ulna is it's the bone. I don't know. If you remember the radius, I mean, how can you possibly mix that up with the ulna? Because they don't articulate in any way. You're like, oh, it might be the radius, it might be the ulna. They only articulate where they meet at bone ends. And if you remember that the radius is on the inside, the radius is rad, and the ulna is outside, you're not going to get confused. There's no way you can get confused. So try to make your life as easy as possible and start committing these bones to memory. And that, ladies and gentlemen, is all 6 of your long bones. And if you think that's the end of the video, no, not even. Nope. So let's take a look here. Now I added this because the lower extremity is a little bit more point and click, very straightforward, whereas we have more bony structures. So I wanted to add this. So we've got the clavicle here and the scapula. You can see where it kind of sits and meets right here. This point is the acromion process, or the acromioclavicular joint. And then you have the humerus. The humerus, that big, long, dense bone, that's the upper part of your upper extremity. And then we have the radius and the ulna. So if you're looking here, it may be a little bit difficult to tell. We are looking right now at either the right arm we could be looking at the right arm in the anatomic position, which is exactly what we're looking at. Remember, that's with the palms facing forward at our sides. Or if this is some wackadoo drawing, it could be in that position from the back on the left side. We're going to go ahead and we're going to say, just for the sake of being as clear as possible, that this is going to be the right side looking from the front, from the anterior position. Here's the radius. Radius sits right here, and I'm going to go ahead and annotate real quick. All right, here's the radius. And you can see that this thumb right here is on the same side, right? Radius is rad. The other side is the ulna, and it's a little bit buried in my source. Sorry, I stole this shamelessly from a website, so I had to cite it. That's the ulna, and that's on the pinky side. Ulna, pinky side. Radius, thumb side. Radius is rad. And then we have the bones that make up the hand. So just like the tarsals and metatarsals and phalanges of the foot, we have carpals, metacarpals, and phalanges. The carpal bones sit right here at the wrist joint. The metacarpals are that very first bone that you have. And then the second and third bones in your fingers, those are called your phalanges. And if you remember phalanges from earlier, it's because them's your toes. Phalanges are toes and fingers. Phalanges. So if you're wiggling your phalanges, if I say wiggling your phalanges, you gotta be doing this in class, but I know that secretly deep down, you're also wiggling your toes like, this is ridiculous. I'm a high school senior. I'm a grown adult. Trust me, not using these terms is not going to help you. Even if it makes you feel a little ridiculous, it's better to do it and feel ridiculous and then not forget when you're in a crunch. Moving forward. So we already talked about these. The wrists are made up of the carpals. The hand is made up of the metacarpals, and the phalanges are the finger bones. The phalanges are the finger bones. So finger bones and toe bones. Phalanges. Phalanges. Okay. We're just about at the end of our musculoskeletal system review. We're going to go ahead and move on to a quick picture. This is available in your textbook. It's also available in the PowerPoints that are available on Canvas, but this is just a breakdown of some of these larger bony structures. Is this every bone in the body? No, not even close. But these are the ones that we talked about in some way, shape, or form over the last 10 slides. So if you want to go ahead and look at this in a more large scale version, you can definitely do that on your own. But I can real quickly go ahead and blow this up so you can see it. Skull, maxilla, mandible. Oh my gosh, look at how many bones we're missing. Look at how many bones we're missing just in the face. And they didn't even break up the skull and the cranium into all of its other pieces. And this, I think, really explains why it's so important for us to use these types of anatomic drawings so that we can help wrap our mind around what we will likely not see in its full actual shape outside of the body, because bones are outside of the body. That's always bad. You're having a bad day if bones are missing. Cool. All right. Finally, we'll wrap this up. We've got joints. Joints are where we are connecting bones to other bones. This is not a sports medicine, kinesiology, or other type class. So getting into the difference between our tendons and ligaments and other type of connecting structures is something that would not serve us well right now, because this is a general overview. We will be talking about those further on when we talk about musculoskeletal injuries, which is a chapter in our trauma block. So have no fear, especially if you're one of my former sports med students, we will talk about it. But let's break this down just as a quick reminder. Joints are anytime that we've got bones connected to other bones. And we've got two types of joints in the body. We've got ball and socket and hinge. And before anyone comes screaming at me, that's the one, these are just what you need to know, okay? Let's keep it simple. Keep it simple. Moving forward, we wouldn't really be talking about the musculoskeletal system without talking about muscles. And again, if you've taken a sports med class, if you've taken a kinesiology class, if you've taken a standalone A&P class, you're probably over there pulling your hair out, screaming, and your family's wondering why you are falling apart watching a YouTube video. Relax. Chill, just relax. Take a deep breath. This is going to be something that we continue to talk about. We have an entire chapter about it. But to give you a top-down look, we have the three types of muscles that we have in our body. We've got voluntary, involuntary, and cardiac. Voluntary skeletal structure or skeletal muscle, this can be built up when we work out. We can make it larger through hypertrophy, or it can become smaller through a process known as atrophy. This voluntary muscle is striated, so it's got the ability to grow larger based on demand, based on use. Involuntary muscle, this is where we have the lining of our stomach, of our blood vessels, and of other smaller aspects of the body, especially in the organs. But this is muscle that we can't make bigger. It is non-striated. So smooth muscle, non-striated, means that it doesn't get bigger or hypertrophy with use or atrophy with disuse. It can only do its intended function at its intended size. And the only way that we can really, kill it off is if we cut off all oxygen supply to it, or we have death of the organ itself. And then finally, we have cardiac. Now, this is going to be, again, very, very brief, but cardiac muscle is somewhat unique. It is partially striated, just like voluntary or skeletal muscle, so it can get bigger with demand. But in a weird way, that can actually backfire and hurt us, and we'll talk about that more during the cardiac chapter. But cardiac muscle is partially or semi-striated, and it's only found in one place. You guessed it, it's in the heart. Now we're going to talk about a couple of these terms. I want to introduce you to the first one, automaticity, right now. Automaticity means that the cardiac muscle has the ability to make its own impulses to cause it to go ahead and contract and relax, contract and relax. If you've ever wondered how your heart does its thing, well, simple terms, stress. A little bit more advanced terms, electricity, very advanced, based on the electrical impulses that are generated from the body due to chemical compounds and the inherent conductivity of the heart. Boy, that sure was a whole lot of words, Eric. I hope you know what they all mean. Yeah, most of them. But cardiac muscle is something that is very unique, because none of our other muscles lift, within our body really need an electrical impulse to do their job. It's either going to be based on demand, so voluntary muscles like our skeletal muscles, or based on impulse from our nervous system, where we get into involuntary muscle. Cardiac, it just does its own thing. So it's kind of a mix of both. It's a little bit of voluntary, a little bit of involuntary, mostly involuntary, but it is unique because it needs electricity to go. So here's just a quick picture to kind of show you the difference between the locations of skeletal muscle, smooth muscle, and cardiac. It's not a great picture in my opinion, but it does give you a general idea of how these look. And if you want some more insight on this, we've got some great posters in class, and we can also find some of these more in-depth videos that I've linked. They're usually the Khan Academy videos because they do a really good job of making it accessible, but going in depth. Moving away from the musculoskeletal system, we have the respiratory system. Now, the respiratory system itself is comprised of a couple different structures, but it's important to understand the very bare bones basics. The respiratory system is going to bring oxygen in by breathing in or inhalation or inhaling, and it's going to get rid of waste or excrete waste, which forms itself as carbon dioxide via exhalation or breathing out. So we breathe in, we bring in oxygen, we breathe out, we get rid of waste, which is carbon dioxide, and that is a repetitive cycle. Now, this is a very simple thing, but respiratory system emergencies and talking about them are so in depth that we actually have 2 chapters in which we talk about it. So if this feels a little, if you've taken a class with me before, and this feels a little basic, it's because, well, it is. This is an introduction. We're not going to be going nearly as in depth as we normally would. And if you are concerned about the respiratory system, this is where we need to get the absolute facts on paper and make sure that we're all on the same page. Cool, let's move forward. Our anatomy is broken up into the upper and lower airway. We're going to start with the upper airway. Air is entering your body through your mouth and nose. We all know this. We all breathe, as a combination between our mouth and our nose. If you're talking a lot like I am right now, I tend to breathe only through my mouth, so my mouth is very dry, and I'm probably going to end up, dying from dry mouth. But when we look at breathing that is outside of speaking, we're typically breathing through our nose. So we are capable of breathing through mouth and nose. Give me 1 second. I'm going to pause my recording real quick and come right back so I can go get some water so I'm not, cotton mouth. All right, we're back. Sorry about that. So, like I was saying before the break, we are looking at respiratory anatomy. We do break that up into upper and lower airway. So we'll start with the upper. Air enters our body through the mouth and nose. The mouth is known as the oropharynx, and the easiest way to remember that is oropharynx. And the nasopharynx, again, easiest way to remember that, nasopharynx. The word pharynx is referring to the passage or the point in which it enters. So the oropharynx and nasopharynx are going to be the mouth and the nose. And when they kind of terminate in the back of the throat here where they both meet, we call that the pharynx, just the pharynx. Air is going to enter through the oropharynx or the nasopharynx, or maybe even both if you're one of those talented multi-breather or continuous breathers, and it's going to move towards the lungs. Now, before we go any further, we need to understand that there are structures in place to protect us from swallowing air or getting food or fluid, anything into our trachea, which would go down to our lungs. So this is where we get into the epiglottis. The epiglottis is a small flap of tissue that closes over the glottic opening that protects the trachea. So the epiglottis is going to make sure that we don't get things down the wrong tube. I kind of don't like that phrase, but it really is kind of the most specific, and that's what generally protects us. Now, these are, again, all just terms, so let's take a look at a picture so we can get a better idea. So we'll move forward, and here we go, the upper respiratory tract. We have the nasal opening here, or the nasal metasis, love that. But we have the nasopharynx. That's all this area. This is all the nasopharynx. The nasopharynx is all that space, and if you've ever wondered, what the inside of your nostrils looks like, there's a passage here, but it really empties out into a large cavern or sinus cavity. This area here is what we have behind our nose, and specifically kind of sits right behind the eyes, or underneath and behind the eyes. And if you ever had a sinus headache, you know what that kind of pressure is. It feels like there's pressure behind your eyes or directly behind your nose. It's because of either inflammation or some type of other pressure that's building in this sinus cavity. It's actually fairly large. Then it empties out back here. And this is another thing to kind of help you understand the anatomy of your patient by understanding our own anatomy. If you've ever had to use some type of a nasal drop or nasal spray, and you felt it go down the back of your throat, this is why. This is exactly where it terminates, is right back here. And if you've ever heard the term post-nasal drip, it's because we have something dripping back here and typically going down and either into the esophagus, or hopefully not, but possibly into the trachea. This is the mouth. Now, if you're looking at, and I'm going to start annotating again, the mouth, this area here, ooh, that was a bad drawing, bad circle, not even a drawing. This area here is the oropharynx, the oral cavity, the oropharynx. But what you're seeing the majority of is, in this picture, the tongue. So this is with the mouth closed, and your tongue is incredibly large, incredibly muscular, well, just that, muscle. So when we open our mouth, our tongue generally sits more flat and is out of the way. Right back here, this area right back here is known as the pharynx. Known as the pharynx. Now the pharynx is where the nasopharynx and the oropharynx meets, so that is the pharynx. Now we have other pharynxes. Pretty sure that's the right plural. So we're going to talk about those in just a moment. Before we do that, let's look at some other things that we've already taken a look at. You see this right here? This little weird looking bluish, cerulean, I guess, or I don't know, color. This is the epiglottis, and that's that piece of tissue that will sit flat right over here, and it will protect this structure, which is very important, the trachea. Now, the trachea is what leads all of our air down into the lungs, and the glottic opening and the beginning of the trachea is the dividing point between the upper airway. So all of this is considered the upper airway. Okay, so I'm going to write it over here. Upper airway. It's right here. Okay. Draw again. Now we don't need text. Let's draw. Okay. This is all of that. Okay. All of that is your upper airway. Anything below that is considered the lower airway. And we'll get into that in just a moment. But this is all the upper airway. So nasopharynx, oropharynx, pharynx, and the laryngopharynx. We haven't talked about that one yet. The laryngopharynx is where our larynx and our larynx is right here, this little small flap, where the larynx covers the trachea. Okay. So now we've got all that kind of figured out. Let's look at some more key terms, make sure that I clear all my drawings, get out of here, and then move forward. The larynx is where we have our vocal cords. The vocal cords, I think a lot of people think of the vocal cords as being kind of in, people say the term voice box, but really our vocal cords are going to be bits of cartilage that are forming rings, and we can actually modulate that pretty easily. If you've ever wondered how they do the SpongeBob laugh, I can show you right now. So take your finger carefully, and by yourself, not on your partner. Do this. By vibrating these, I just remembered that I've got my SpongeBob thing up in the back. By vibrating these areas right here, we can modulate sound, and we can make our larynx change tone by adding pressure. But that is where we find our vocal cords. We also have rings called our cricoid cartilage, and that will become more important as we get into those chapters on airway management and respiration and ventilation. But for right now, just know that this is what creates the structure of our trachea. And we're going to move down to the trachea. The trachea is, and I hate to use these terms, but they're ones that resonate. They make sense to you. This is our windpipe. It's right here. You can feel it. You can touch it. If you've ever wondered how you get air in and out, it's right back here. So if you've ever thought to yourself, or if you've ever said, oh, I'm choking, and you point right here, that's not anatomically correct. Your esophagus is further back. It is located posterior, so further back, to the trachea. The trachea is located anterior, and it is going to be very prominent right here. And we've got those cartilage and our larynx. It contains our voice box or our vocal cords. It's all right here. As we move further down the trachea, and now we are, again, at that trachea line, that's when we're in the lower airway. We move further down and we get into the lungs. Now, before we get to the lungs, we are going to be looking at some structure, but these lungs are going to be fed by one main trachea, so main stem, and then they break off into the left and right. Where they break off, or where they kind of divide into two, they do something called bifurcation, and I'm going to write that on the slide here. So where the trachea divides is the bifurcation point. Okay, bifurcation point. And the bifurcation point is also where we find the carina. Okay, so bifurcation leads to carina. Yuck, I hate that arrow. Undo. Cool. So now that we got all that figured out, we can move a little bit further down. Now the lungs are made up of, and the easiest way to remember this is that they are bags that are filled with air. That is such a simple and very, very, uneducated way to say it, but we got to start somewhere. So they're bags that fill with air. Simple. Inside of these bags that fill with air, every time that we breathe in and empty every time that we breathe out, we have structures known as the bronchi and the alveoli. The bronchi are structures that are larger. They line the surface of the lungs, and they are where we find the majority of the inflammation that we deal with on a regular basis, non-emergency kind of stuff like bronchitis. So these are larger tubes. Then we have the alveoli. And the alveoli are these tiny grape-like structures, and this is where the magic really happens. The alveoli is where we have the exchange of oxygen, and on the other side, the exchange of carbon dioxide for good going in, bad going out. The bronchi are the big passages, the alveoli are the small ones. The final structure that we need to talk about to make sure that we understand all this is the diaphragm. Now, the diaphragm is a small, it's a thin piece of musculature that sits right at the base of our rib cage or our sternum, right there at the bottom, and it moves up and down every time that we breathe in and out. Simply put, without the diaphragm, we wouldn't be able to breathe without great effort, which might not even be possible for some patients, especially if they're very old, very sick, or very hurt. So the diaphragm is really, really important. And something that usually I find helps my students remember things is understanding what the diaphragm plays in other things. Have you ever had a hiccup? Probably. I think everyone has. If you've ever wondered where hiccups come from, it's because your diaphragm is spasming. So that piece of musculature, that thin piece of muscle, is quivering really quickly, just quivering, and that's what's causing you to go and have that hiccup. Another thing that can help us remember what the diaphragm is and kind of where it's located and how it feels is if you've ever had the wind knocked out of you. So we talked about how a hiccup is where the diaphragm is, spasming. When you get the wind knocked out of you, especially if you get hit right in the stomach or maybe land directly on your back, and it feels like you really can't breathe, that's because the diaphragm itself isn't spasming, it's constricted. It's like really, pulled itself tight. And this is not a muscle that we would normally be able to do anything with or flex independently. This is kind of an involuntary muscle. So now that we understand what the diaphragm does in ways that we can understand and functionally use in our brain, now we can kind of put a face to a name. Moving forward here, we have this structure. Again, I'll let you guys see this. This is on slide 79, appendix 4, and you guys can also see this in the textbook if you've ordered that. If you haven't ordered the textbook, definitely talk to me so we can make sure that we get that at the best price. And now we're going to talk about the more important and frankly the more in-depth stuff. As we inhale air, we are actively asking the diaphragm and the muscles in between our ribs to contract. The diaphragm is that thin piece of muscle that sits there at the bottom of the ribs. But we also have muscles in between our ribs, and they're known as the intercostal muscles. Those intercostal muscles are contracting, the diaphragm is contracting, and it's moving downward. So as the diaphragm moves down and the ribs move out, a lot of people think to themselves, oh, that's just allowing the bags of air to fill. Now, that would be functionally correct, it's half correct, but what it's also doing is it's changing pressure inside of the space that holds the lungs. See, in a normal setting, our lungs are under pressure. So if you exhale all the air that is inside of your lungs, your diaphragm is going to relax, your intercostal muscles are going to relax, the entire space of your chest will get more compact, and that is air that's going to be forced out. That is half of breathing. The other half of breathing is how the pressure changes. Sorry for all that running around. Apparently, it's time for my cats to run around. So when we are at a state of zero, completely, exhaled, we have positive pressure that's keeping the lungs closed. As we go ahead and we breathe in, we go, our chest cavity gets bigger, our diaphragm drops, and that pressure changes from positive to negative. Because there's no more pressure, we're actually able to fill those bags. Now, a lot of people have asked, Johnson, that's kind of a complicated concept. Can you explain it a little bit differently? Yeah, absolutely. Watch this. If you've ever done this before, you'll already know kind of where I'm going. But if you haven't done it already, go ahead, pull out a Ziploc bag and get something that's full of water. Go ahead and add some air into that bag and close the majority of the Ziploc bag. When you're done with that, go ahead and dip that bag, and eventually you're gonna have to pull it down. Watch what happens to all of that air. It's all gonna get pushed out. Now, if you were to go ahead and seal the bag, you would see that all of the air would be forced to the very top. That's the way that this all works. It's all going to get forced to the very top, but because it doesn't have anywhere to go, it's going to become trapped. Now, that is where we're adding positive pressure. So when we're pulling that down into the water, that's like when we are relaxed. If we were to pull it back out and we were to change that pressure from positive to negative, then the bag would be able to expand and move air throughout the rest of the bag. And that process is what happens every time we breathe in and out. Now, inhalation and exhalation are different. Inhalation takes energy, it takes effort. And if you think about it, if you take a breath in right now, that takes energy. But if you breathe back out, that is a passive process. It doesn't require energy. And if you ever wonder why it feels so good to take a deep breath or sigh, deep breath and then breathe back out or sigh, it's because it doesn't require energy, but we can feel that there's a change that's happening. It's a little bit of physiologic, a little bit more psychosomatic, but really we're self-soothing by allowing our body to feel like it's accomplished something without having any real expended energy. That always feels good. It's kind of like finding a $20 bill in your pocket. You didn't have to work for it probably, or your brain doesn't say, I had to work hard for that. So you're like, great, 20 bucks, awesome. See? Process of, risk and reward. Anyway, exhalation, like I said before, it's a passive process. The diaphragm and the intercostal muscles relax. Positive pressure pushes all of that air back out of the lungs. And then we start right back over again. And we're looking for a range of 12 to 20 of these, inhalations and inhalation-exhalation cycles per minute. That's right. Every time that your patient breathes in and breathes out, that's one respiration. We're counting one. Okay, moving forward. And again, if this is complicated or confusing, I would point you to the videos that are available on Canvas, or you can go ahead and you can take a look at some of the Khan Academy videos on the respiratory process or respiratory cycle. Now, this is where we start to get into vocab words. So these are words that you definitely need to be able to understand, be able to recite, and be able to write down at any given moment. So we're going to start with ventilation. Ventilation, and yes, these are two very different words. Ventilation is the movement of air in and out of the respiratory system, or as we say in my class, it's the movement of gases in and out. The movement of gases in and out. So ventilation is in, out, in, out. It's ventilation. That's all it is. It's a very, very simple process. Now, if we were somehow able to get something out of just ventilation, then that'd be great. You know, that would be like, you know, how photosynthesis works. You apply sun to a plant, photosynthesis, it does its thing. We're not that simple. We are not simple creatures. We are not simple organisms. We're complicated organisms. We are very, you know, we are very, you know, I'm not going to say it. We are extremely complex is a word that I think is best to use here. We're complex organisms. So what we need to do is not just move air in and out. We have to pull gases from the atmosphere, and then, you know, again, through gases, get rid of waste. And that's where we get into respiration. Respiration is the exact term is the exchange of gases at the alveolar level. Now that's a very wordy thing to say, so I'll say it again. Exchange of gases at the alveolar level. So that's the definition. But what we're saying is that we are putting oxygen in and extracting carbon dioxide to go back out as waste. That is the exchange of gases, and that's occurring in the alveoli, which we talked about a little bit earlier, are kind of the terminus, where the lung fields end. That's where the magic happens. So now that we've got that, and I'm going to keep saying this, if this is still confusing, go back, rewatch that area, come back again. The physiology of respiration is simple. Oxygen is carried in to the lungs, then to the heart through blood, and it's pumped out to the rest of the body, again, through the blood. When we look at it from the cellular level, oxygen is exchanged with cells. So we give them oxygen and they give us back carbon dioxide. Once that process has occurred, blood is returned back to the heart and then to the lungs so that we can get rid of carbon dioxide and start the process over again. So if we were to do this in a fast form, we would say oxygen comes in through the lungs, it's exchanged with the cells and put into the bloodstream. And that's moved through the heart and the rest of the body to oxygenate all of the organs. In that exchange, when they're getting oxygen, they're also offloading all the waste. So it would be kind of like if you were to do some kind of a, I don't know, some kind of an exchange program. Let's say that you've got some type of like a water, like an external water system at home where you have to swap up those big bottles that you see in offices and stuff like that. Well, they don't just, you know, give you all the bottles and then you throw them away. You exchange the empty for the full. So what we start with is the full bottle. Once we empty that out, we need a new one. We exchange bottle for bottle. That should make sense. As the process occurs, you know, hundreds and hundreds of times per day, we are constantly making sure that we have oxygen coming in and carbon dioxide going back out. Is that a perfect one-for-one exchange? No, not always. And carbon dioxide is going to definitely be found in other aspects of waste. And we have waste in a lot of different areas. It's not just exhaled. However, that is where the majority of our carbon dioxide is found when it comes to waste product. Okay. We're doing good. We're doing good. So now we're going to be able to start cruising a little bit. Just a quick little side note on respiratory physiology between adults and pediatric patients. I'll make this quick and brief. The respiratory anatomy of a child is very different than that of an adult. Their mouth is much smaller and their nose is much smaller. They're primarily driven by nasal breathing as opposed to mouth breathing. Their tongue is disproportionately larger than the rest of the structures of their mouth. So they've got a big tongue and a tiny mouth, which is pretty impressive considering how much back talk I see kids giving to their parents and how much time my child spends screaming. But their tongue is disproportionately larger than the rest of the structure of their mouth. Their trachea is also very narrow, and it's not really as flexible as but forming of structure as that of the adults. And the example that I use with my students is the difference between a straw that is a bendy straw and one that's a non-bendy straight straw. The bendy straw is that of the adult. Strangely enough, it's very flexible, but it holds its own structure. So we can bend that in a million different ways, and we can drink out of it all different angles. The anatomy of the trachea of our pediatric patient is like the straight straw. You can bend it a little bit, just a little bit though, because if we go too far, it's going to end up kinking, and then you can't get anything through it. Best case scenario, you just have to put it back, and then we're good to go. Worst case scenario, we ended up breaking it. Now, in the case of our child's airway, we're not going to break their trachea, but we can pinch it completely closed. So we need to make sure that we are being mindful of that anytime that we're positioning the airway. And we'll talk more about that during CPR. Also, the reason that their trachea is so easy to kind of close and collapse based on angle is because the cricoid cartilage is less rigid and less developed. So we don't have as much, and it's definitely not as rigid and formed as that of the adults. And finally, things are smaller. Their nose is smaller, their mouth is smaller. And as we definitely look at the littlest kids, so we're looking at infants, definitely toddlers, preschool age. What type of airway obstructions do you think we typically see with them? I'll keep it nice and easy for you. Anything that can fit in their mouth or nose. So when we deal with obstructions to the airway of these younger pediatric patients, it's usually because they've stuck something in their nose or stuck something in their mouth. So we have to be kind of considerate of that. All right, moving forward. We are outside of the respiratory system. Now we're talking about the cardiovascular system. Yeah, baby, woo! So now we're talking about the heart, the blood vessels, and the blood. So the heart is known as the pump, the blood vessels are the pipes, and the blood is the fluid. We're going to start seeing that things are a little bit different here than they are on the slides that you have available on Canvas. So just be kind of aware of that. Okay. The heart, in its most simple anatomy, we can break it up into 4 chambers. We have 2 atria, and the atria are the upper areas, and the 2 ventricles. So the easiest way to remember the difference of where they're located, atria sounds like atrium. Atrium is usually like a balcony that's above you, right? Atria, atrium, above. Above, atria, above. Cool. The ventricles are, by form and function below. They can't be above because they have to be below because of the way it is. So we've got 2 atria, 2 ventricles, and that's broken up into the left and right side. So originally this said pathway of blood through the heart. I added the comma simplified because this really is very simplified. Right atrium, right ventricle, left atrium, left ventricle. Oh, PowerPoint, you silly dog. That would be so nice if it was that simple. And, again, this is a very, very, very simplified version of the way the blood flows through the heart. It enters the heart through the right atrium, drops to the right ventricle. It is brought back into the heart from the lungs with the left atrium, and then pushed back out through the left ventricle. Boom, right? Simple? Not really. And when you see the next slide, you'll understand why. This is your heart. So somehow the publisher of this slide, God bless him, thought that this translated to this. It does not. Now, this is a great picture. I will not sit here and beat this picture up. I think it's a wonderful picture. I think that it does a great job, but it does lose some of the value that the simple version we just had really presented it with, because the heart's it's a very complicated organ. We got blood that's being pumped in as it's being pumped out. It's a very, very active pump. So we're going to move forward, and if you're feeling confused, don't worry, we spend an entire chapter on this, and as a group, you and your partner or partners will be making and presenting a diagram showing the flow of blood to the heart. So this is one that I found on wikimedia.org, which I don't know why it's not, I don't know, Wikipedia, whatever. It's a great picture. I just want to make sure that the sourcing is there so I don't get, the ban hammer from YouTube. But this is a much easier way to understand how blood flows through the heart. So if you look here, a couple quick notes, and I'm going to annotate. So boom, right here. You see how this stuff right here is blue and this stuff is red? Anything that's in blue is moving deoxygenated blood. It's moving deoxygenated blood, and specifically it's moving it back towards the heart. So through the superior and inferior vena cava, we have blood flowing into the right atrium, the right side of the heart. From the right atrium, so that's the top, it hits the tricuspid valve, and in the tricuspid valve, it bumps down into the right ventricle. So the right ventricle is directly below the right atrium. Moving from the right atrium through the pulmonary valve, we have everything flowing into the pulmonary artery. And we haven't really talked about it yet, but there is a common misconception that all arteries move oxygenated blood and all veins move deoxygenated blood. That's not correct. And this is exactly why. The pulmonary artery is actually moving deoxygenated blood. So what we say in class is that arteries always move blood towards the heart. Excuse me. So sorry about that. Oh my goodness. I am absolutely falling apart here. The veins move blood towards the heart. Arteries move it away from the heart. Cool? So once we get to the pulmonary artery, it goes to the lungs. And from the lungs, we have oxygenated blood. And you can see where it's turning from blue to red. We got purple. We hit the left atrium. The left atrium right up here through the pulmonary vein. We go in through the pulmonary vein. It hits the mitral valve, also known as the bicuspid valve. So right here, the bicuspid valve, to the left ventricle. And then from the left ventricle, it goes out to the aorta, and the aorta is going to feed the rest of the body oxygenated blood. And then we start the cycle back again at the superior and inferior vena cava. And this is a really complicated subject, and the videos that I have posted in Canvas that are linked out to Khan Academy, they're fantastic. If you have another resource and you think that it's even better than the videos that I posted up, by all means, tell me. I love getting new resources and new things to share with students, and I will absolutely give you credit for being that person about it. So bring it on, bring it on. But again, this is a complicated subject, and this is the kind of thing that a lot of people will ask during a more complicated job interview, because job interviews as EMTs is not just sit down and say, oh, well, what do you want to do this job for? Okay, well, here you go. It's going to be a test of your ability to interview well, to understand what you've learned and understand skills. So it's a whole process. And I've received this question on more than one application or more than one interview. Tell us about the flow of blood through the heart. As long as you have a definite start point and definite end point, you're good to go. I always start at the superior and inferior vena cava, where we are moving blood into the heart on the right side. That just makes the most sense to me. Some people like to start on the left because that is where you have blood oxygenating the heart and then the rest of the body, but I'll let you make that decision on your own. Just a quick little thing, a little bit of trivia for you. What organ is the very first thing that receives oxygenated blood? The very first organ that receives oxygenated blood is the heart. It's got to oxygenate itself. So that's a super common question on interviews. It's a super common question that you can see in interview prep as well as the National Registry prep. And I definitely have seen some of my tests reflect that. But if you ever see that question, the first organ that is oxygenated is the heart. Cool? All right. Now, we talked about this a little bit earlier, but this is all done through a complex system of electrical conductivity or automaticity in the heart, the generation of electricity throughout the heart. We're going to look at that cardiac conduction system on the next slide. Make sure that we are good to go. Moving forward. Now, you can see some of the overlay of the different arteries and veins, the aorta, the superior and inferior vena cava, but really what they want you to focus on here are these yellow areas, and these yellow areas are pathways. So to keep things simple, because we are going to go through this during a cardiac chapter in depth, the pathway of electricity starts up here, number 1, and we're going to go 1 through 5. And this is a very simplified version, but it starts up here in the sinoatrial node or the SA node. Ooh, I don't like that. There we go. Let's go something a little darker. So we start up here with the SA node. Now from the SA node, it'll come down right here through these internodal pathways. You don't need to know what the internodal pathways are. It'll meet another junction point, and that's known as the atrioventricular node. So the first node, the sinoatrial node, is referred to as the SA node. The SA node is known as our pacemaker. This is what keeps the rhythm of our heart. It's the rhythm of the heart. Oh, yeah. Yeah, SA node. Yeah, you're welcome for the free song, too. I'm probably going to get banned on YouTube because I just stole someone's song. Boo. The next one is the atrioventricular node. That's the AV node. So SA node, AV node. Cool? Now, as we go further down through the heart, we're going to see that there is a definitive pathway. So we're going to start, I'm going to clear all this. So we start here, we go here, And then we bump down to this area here. This is known as the AV bundle, but we really refer to it as the bundle of His. Bundle of His, not bundle of His, bundle of His. So the bundle of His is where I get real frustrated. Just, you know, from the paramedic side of things, this is where things always got complicated for me, because this is where we have our bundle branch blocks. But I know that if there are paramedics out there, or, you know, doctors out there, they're probably chuckling to themselves saying, well, you're just probably too dumb. Well, that's why I teach. You know what they say, those who can't do, teach. So here I am. After we get to the bundle of His, we have our bundle branches. These branch down here. Ooh, looking so fancy, bundle branches. And as we go down the bundle branches, we have these tiny little spaces here that look kind of like little fibers, and thank God they are. They're called the Purkinje fibers. Now I'm tracing out some of the Purkinje fibers. Cool. And they all go off these bundle branches. Now, the way that this works, excuse me. Gosh, it's getting super late. I'm starting to drop words. The way that all of this works is that all the electrical activity starts up at number 1, the SA node, bumps down to the AV node, hits the bundle of His, goes down to the bundle branches, and then pushes onto the Purkinje fibers. As each aspect of the heart is affected by that electricity, and it is hit by that electrical current, it causes the heart to contract. It causes it to squeeze. And that's super important to see here, because it causes these chambers to close. Once the chamber closes, it forces blood out. So we talked about this earlier. This right here is the right atrium. When the SA node fires, the right atrium pushes blood down through here, through the tricuspid valve, into the right ventricle. As the AV node and specifically the bundle branches fire, the right ventricle is going to squeeze, and that's going to force blood out of the heart. So we're going to force blood out of the heart. As it's forcing it out of the heart, it is going to head over to the lungs. As it heads over to the lungs, it's going to reoxygenate it and brought back into the heart. So we're back up here in the left atrium. The left atrium is going to be controlled by, again, the SA node, but it's a little bit further off. You can see that there's, and distance does make a difference here. You can see that right there, see? And then we got our little Purkinje fibers, but that happens in an instant. So you have this, right side, left side, right side, left side, right side, left side. But they don't go at the same time. They can't go at the same time. They have a tiny little bit of a, pause. That's that lub dub that we talked about in the last week that I was in class. So as that is causing that to contract, blood is being forced from the left atrium down through the bicuspid valve or mitral valve into the left ventricle. And as this area, so again, we're following from here, down here, and then we're going down this side. All of this is being forced to contract, which pushes oxygen-rich blood into the rest of the body. Now, that sounds super easy, but the best way for us to describe this is going to be using a video that I did not make. So I've got that linked up in Canvas, but also to see this in an actual heart, a beating heart, which I would be unable to show on YouTube because I don't own it. So what we'll do instead is we'll show that in class. And this will be especially important when we go over our chapter, completely covering cardiac, which is chapter 20. Cool? Cool. Now, when we're looking at this in the grand scheme of things, we have important arteries that we need to know. I'm going to go ahead and annotate here again, real quick. I want to make sure that we keep these separate. So, shooby-dooby-dooby, all the way down to the pulmonary arteries. So everything above this big old ugly line that I drew, these are arteries that we're going to be able to only find in our heart, and really, we're not going to have the ability to assess them in any specific way. The exception to that rule is the aorta. We'll get into that more a little bit later. But really, the coronary arteries, the aorta, and the pulmonary artery, that's all going to be directly in the heart itself. We can't mess with these, but you do need to know what they are. The next arteries that we see below that other line that I drew is the carotid and femoral artery. These are central arteries. Central arteries are used to assess patients that are unconscious, unresponsive, or we simply cannot feel or palpate a pulse anywhere else. These are very big. They move massive amounts of blood. Severing one of these arteries, the carotid artery, the femoral artery, would be, mostly fatal. Not 100% fatal, but for most people it would be fatal, and it would be fatal within a few minutes. Not very long if you sever one of these arteries. So they're very big and very important. Moving forward, we have these arteries. Now, the brachial, radial, we'll talk about these all in just a moment. These are known as peripheral arteries. Peripheral arteries run in our extremities, so our arms and legs. The radial artery, that's the radial, the rad. Remember, we talked about that. The brachial is up here in the inside of the elbow, or maybe a little bit higher up on this aspect of the arm, but it's right up here. The other two that we see here, the posterior tibial is right behind or just out to the outside, the medial aspect of the tibia. So it's kind of in the back of the leg. And it can be confused with the popliteal, which is right behind the knee, but the posterior tibial artery is extremely difficult to palpate for most people. And the last one that we have here on this slide is the dorsalis pedis. The dorsalis pedis is located on the top of the foot. And that's an excellent one to assess if we're dealing with a patient that's experienced some type of an injury above the foot or on the foot itself. Just a quick note though, this is the posterior tibial and dorsalis pedis are not arterial pulse points that we check very often, and certainly not ones that we would ever check to make sure that a patient had an effective heart rate or the presence of a heart rate. And speaking of that, we would never use a radial or brachial artery to check for a pulse on any adult patient. We would go straight to a carotid. The only time that we would ever use the brachial artery is if we're checking for a pulse on a baby, so 0 to 1 years old, regardless of if they are conscious or unconscious. Now the next slide that we, the next slide that we have here is just a quick little picture explaining the difference between veins and arteries and how they make sure that blood gets out to the rest of the body. But to keep it simply, as simply put as possible, arteries move blood away from the heart, whereas veins move blood towards the heart. The arteries move blood away, veins move blood towards. Now, we need to make sure that blood gets to all the organs, to the skin, all the different aspects of the body, and it's not going to be effective to have a huge system of all these different pipes running through the body. Arteries and veins are very big. We have to have smaller ways to move these things around, and that's where we get into arterioles and venules. So as you can see here, it's broken up into these smaller little spots here. So we've got the big vein here, we've got a valve, the bane of my existence, trying to start IVs, and then we've got the artery. And I'm going to go ahead and clear that real quick so that we're not confused, because we already know what these are. Okay, those are big pipes. We can't get things effectively to the rest of the body with these big pipes, or else they're going to basically end up being flooded. I mean, imagine trying to water your grass with a fire hydrant. It wouldn't work. You'd kill the lawn. And we're in the middle of a drought, so you shouldn't be watering your lawn anyway. So we have to move to something smaller. We have arterioles. So if you're thinking of it from that example of trying to water your plants, think of the arteries and veins as being fire hoses, whereas the venules and arterioles are more like a garden hose. Now, garden hose is great if you want to water things like your lawn or you want to wash your car, but if you're trying to wash something that's really delicate, like let's say that you're trying to water a bed of flowers or something, you probably wouldn't use a hose, and certainly not without putting your thumb over the top, getting that fine spray. But for the most part, you don't do that because you could still kill the flowers. So we have the smallest of these blood vessels, and that's where we get into our capillaries. The capillaries are that fine mist, that very, very fine mist you get when you use the special settings on your your hose attachment, or if you take the water and you put it into a watering can. That means that we're not going to overpower what we're trying to get blood to or blood from. So capillary beds is really where all of that exchange happens in the bloodstream. Now, we need to talk about the composition of blood. Blood is made up of 4 equal parts, or no, I'm sorry. Strike that last part, not 4 equal parts. It's made up of 4 parts. These 4 parts are plasma, red blood cells, white blood cells, and platelets. Plasma is the volume of the blood. That's where we get the movement of fluid, so water and nutrients, And if you've ever gotten cut and had a wound that healed and you didn't put a bandage over it because you don't care about getting sick, you've probably seen that yellow stuff that pops up. That's plasma. Plasma is that yellowish stuff that you can get on the top of some cuts, not all, but some. Red blood cells are specifically going to be moving oxygen via hemoglobin. So having all this great stuff, red blood cells, we're moving the important stuff, oxygen, right? White blood cells are responsible primarily for fighting off infection. So they send out leukocytes, white corpuscles, and other fighting aspects of our body to fight off infection and fight off foreign invaders. And then finally, we have platelets. Platelets help with clotting. So whenever we get cut, our body is designed to stop bleeding. And, I hate to be glib about it, but all bleeding does stop eventually. But that's where we come in. If we have someone that's bleeding and that bleeding isn't going to stop on its own, or if it does stop on its own, it'll be when they're dead, then we need to, help the body form a clot. So as we're looking at this list, you need to know one specific aspect of each of these 4 components of the blood. Plasma, volume, move to water. Red blood cells, you're moving oxygen on hemoglobin. White blood cells fights infection. And platelets forms clots, helps with clotting. Cool? Make sure that you know those things, because if you don't, this class is going to be hard. And by hard, I mean impossible. You have to know these. Move forward, the pulse. This is the pressure wave blood that moves down an artery when your left ventricle contracts. So as blood is leaving the heart, entering the body, oxygen in the blood is leaving the heart and going into the body, you're feeling this on the artery points that we've talked about before. And we can feel a pulse by compressing an artery over a bone. I'm not going to get too deep into this because we've already talked about this in chapter 13, but for those of you that have yet to watch the video, don't know why, or weren't in class for it, please go watch that video, chapter 13. It's already up in the channel, so you can watch that directly after this, but really you should have watched it before. We have peripheral and central pulse points, which we've actually already talked about. So the peripheral, again, are the radial, brachial, posterior, tibial, and dorsalis pedis. Okay, radial, brachial, posterior, tibial, and dorsalis pedis. And the central, the core of the body, are going to be the carotid and femoral. Now, again, I understand that there are probably some of you that have a more advanced education when it comes to anatomy and physiology, and you're probably pulling your hair out again. Seriously, stop pulling your hair out. This video is just video. Stop watching. Yep, makes you that upset. But we do have other pulse points. These are just the ones that you really need to know for this class. Okay. Now, pulses that are closer towards the body are known as central pulses, and these should be used if either peripheral pulses are too weak or if the patient is unconscious or unresponsive. And that really comes right back to what we've talked about in CPR, or what we will talk about if you haven't done that class yet, where we need to check and decide really quickly, hey, does this patient have a pulse? Because radial pulses can be weak enough to the point that we can't feel them, and sometimes even brachial pulses can be weak enough that we can't feel them. If you fail on one, and you fail on one, you should go for the carotid. If your patient's conscious, if they're awake, I promise they have a pulse. I've been doing this for almost 15 years. I have yet to find a single patient that was pulseless and talking. Because being pulseless is the clinical definition of death. You can't talk after you're dead. You're dead. So, water into the plasma, into the blood. All right, moving forward. Blood pressure. As blood is forced into the arteries, we're looking at the effectiveness of the pump or the heart, the blood, so how much of that fluid we have available, and the blood vessels and their ability to maintain their structure. So again, this is a bit of this chapter that you don't need to get too deep into if you've already watched chapter 13. If you haven't watched chapter 13, please go and do that, because I've gone into some significant detail on all of this, but we'll do a quick review. The systolic, or top number or upper reading, is the arterial pressure, how much pressure is in the arteries as the left ventricle contracts or squeezes shut and forces blood out into the body. The diastolic, or the lower number, the bottom number, is the pressure that's left in the artery as the left ventricle is refilling. So left ventricle contracts, systolic, left ventricle refills, diastolic, arterial pressure is what we are measuring. That's why we have to use a blood pressure cuff, so that we can try to stop that or slow it enough so that we can get a rush of pressure and we use our stethoscope so that we can listen over arterial points, most commonly the brachial arterial pulse point. Shabuzi. Now, we talked about blood. We've already talked about the pump. Sorry, let me rephrase here. We talked about the pump. We've talked, pretty decently about the pipes, and we've definitely gone in depth on the fluid. So now we need to talk about the concept that goes behind all of that working in the system itself. This all comes down to one single key term, and that is perfusion. So perfusion right here, super important. Ooh, kind of messed up. Perfusion is a super, super important thing for you to know. The definition of perfusion is the adequate supply of oxygen and nutrients to the cells of the body with the removal of waste products. I honestly can't make that any more technically correct. So what I will say is this: perfusion is the adequate supply of oxygen and nutrients to the cells, or the adequate supply of oxygen and nutrients to tissues. But really, it does need to get to the cellular level. So if the cells aren't available, if they can't use that, then the tissues are going to die anyway. So adequate supply of oxygen and nutrients to the cells, that's what we're looking for. All the way complete, we also have to remove waste, but as long as they're able to accept all these things, typically removal of waste products is a given. Not always, but usually. Anytime that we have hypoperfusion, and remember, we've talked about the word hypo before in medical terminology. Hypo means low. Hypo, low. Hypoperfusion is low perfusion or inadequate perfusion, which leads to a state of shock. Now, I think that a lot of people don't really understand what shock is. We're going to break this down in a different chapter. It's actually got different categories and subcategories. But shock is not the, oh, I'm so shocked, I got an F on that test I didn't study for. That's physiologic shock. I'm sorry, that's not physiological shock. That is psychological shock, or really, it's probably more just denial. But that's not the type of shock that we're talking about. Because you got a bad grade and you're like, I'm not going to go to college, am I? That's not shock in the physiologic sense. Physiologically means that we are getting inadequate oxygen or nutrients to the cells. And especially in the case of sepsis or septic shock, we have very little or no removal of waste products. So basically, hypoperfusion is when perfusion becomes inadequate, and we call that shock. So here's one of those fun slides, think about it slides. It says, how is the function of the respiratory system related to the function of the circulatory system? Well, I can tell you very simply, but I want you to think about this on your own. How do these systems tie together? We'll go ahead and we'll talk about this in class, but I don't want to give you all these answers. They should be fairly straightforward for you if you look at it. And let me prompt another question. If one of these systems fails, can the other survive? If the respiratory system fails entirely, can the circulatory system continue to function? If the circulatory system fails to function, can the respiratory system survive? And if we're looking at the respiratory and circulatory system, can the cardiac system survive without these? And we can extrapolate even further. If the cardiac system fails, can the brain or the neurological system survive? So as you can see, these body systems are dependent on one another. It really is somewhat of a house of cards. If you start to remove small parts of systems, other systems will try to compensate, but eventually they'll start to fail. And we have critical ones, and these are the ones right at the very bottom of that house of cards that create the foundation. If you pull them out, the whole thing collapses regardless of how carefully you do it, because if you remove it entirely, it will not stand. So life support chain. We have to have the interaction of the respiratory system, the cardiovascular system, and specifically the cardiopulmonary system working all together for perfusion to exist. Perfusion means cells are oxygenated, waste is removed. Cells oxygenated, waste removed. If you think of this as a triangle, you will help yourself immensely. The triangle is the heart, or the pump, the pipes, or the blood vessels, and the fluid, or the blood. If you remove any one of those things, you no longer have a triangle, it will collapse. Okay, so if you're looking at this slide and you're just focusing on that, look up here. If you remove one of those sides, it cannot exist. It collapses, okay? So you must make that happen. I don't know why I keep doing this, but it's fun. If someone wants to make a TikTok video out of this, go for it. Here's the dance. Go ahead and, I don't know, throw it to, I don't know. I'm on a Billie Eilish kick. Go throw it to a Billie Eilish song. I don't know, TikTok dance. All right, moving forward. We are now moving outside of the core systems that we've been talking about the blood, about the vessel, the blood vessels, the heart. We're moving away from all of that, and now we're moving into individual organ systems. So we need to excise our brains of that for a little bit. We're gonna, definitely need to come back and review, but now we need to talk about other aspects of the organs and how they all work together. So very far removed from that, we have the lymphatic system. The lymphatic system is primarily in charge of capturing fluid and maintaining balance of that fluid. So again, maintaining and capturing fluid. You're probably wondering why the lymphatic, or as many of you know, the lymph nodes, why it's so responsible for that. Because you've been traditionally taught, hey, lymph nodes are all about when you get sick. That's not incorrect. That is a fair and factually correct statement. It is responsible for your immune response in a small way, but its primary job is maintaining and capturing fluid. And that fluid that exists outside of the blood vessels, because remember, blood isn't just moving oxygen and white blood cells and platelets to cause clotting. It moves plasma, which provides the volume, but also moves fluid. So the lymphatic system and your plasma and your blood are very, one and the same. They need to work together. So that's the functions: fluid capture, balance of fluid, and immune response. What organs are part of the lymphatic system? Don't worry, nobody. I'm going to tell you right now. Boom. The lymphoid organs are the adenoids, the tonsils, the spleen, the thymus, and the individual lymph nodes that are located throughout the body. And the ones that people are usually most familiar with are like the ones that are right here, kind of up all up in your crotch. Okay, right up here under the, what bone is this? Yeah, that's right, under the mandible. And then the other ones that a lot of people know are under the armpits. And if you're thinking to yourself, under the armpits, like inside the armpits, go ahead and think about that the next time that you get sick. Try to push up against your armpit. It might be a little bit painful. And that's because lymph nodes tend to become swollen when we're sick because they are working on fighting infection. So fun little thing to add in. Now, there is an important note here, and that's why I talk about the lymph nodes that are in that axillary spot in the axilla. It actually relates to our female patients, especially after they've had what's known as a mastectomy. We're going to talk about it right now. Mastectomy is it's the removal of breast tissue, typically to prevent or to treat the onset of breast cancer. And it's a very invasive process. I know that we're all familiar with the push for the cure to breast cancer. We spend an entire month doing pink as an awareness drive for the cure for breast cancer. But it's not enough for us to just wear pink. And believe me, we do wear a lot of pink in the fire service and in EMS to support those causes. But we need to understand that if we have a patient that has had a mastectomy, that we are not to take a blood pressure on that side. And the reason is because with the mastectomy, they also remove a lot of those lymph nodes. And by taking a blood pressure, it can cause a lot of different problems, from, the simplest being pain. We can cause a lot of pain to our patient. We can also cause fluid backup in the area, and it can actually throw off lab results, and it might make them look like they are ill when they're not actually ill, because it can throw all their numbers out of whack. So if your patient is at a mastectomy and you go to take a blood pressure, believe me, they'll say, whoa, I had a mastectomy. They will tell you. And if they are not able to tell you, if you're dealing with a patient that's a female and you're not sure, hey, you know what? Never hurts to ask. But now more and more we're finding that these patients will have some type of bracelet, jewelry. I mean, I've even seen some female patients that have had a tattoo on their arm where the cup would go that says no BP or no blood pressure mastectomy. And it's like, all right, boom, cool, we're good to go. All right. Here's another one of those pictures that you can use. This is breaking down the nervous system. Normally in class, I would show a breakdown of a set of nerves that were painstakingly over the course of like a year and a half removed from a cadaver and laid out on a large piece of paper back in the early 1900s. There's only 3 models in the entire world that exist of our nervous system that are pulled out of the body, and it's wild to look at. But we have just, you know, unbelievable systems in place so that our body can be sent messages from the brain through the spinal cord to the end destination. So let's break these down. We have the central nervous system, or CNS. That is broken up between 2 organs, the brain and the spinal cord. That's it. CNS, brain, spinal cord, that's it. There's nothing more to it. Then we have our more specialized systems, the peripheral nervous system and the autonomic nervous system. The PNS is the sensory nerves and motor nerves. So this is what gives us feedback from the world around us and also gives us the inclination or the impulse to, hey, I need to move around, I need to do something, or I want to move around, I want to do something. So we get that from the peripheral nervous system. The autonomic nervous system is what controls involuntary motor functions. And honestly, these are the kind of involuntary motor functions you wouldn't want to be in charge of anyway. These are things like stimulation to breathe, digestion, and the like. So central nervous system, those are the structures. Peripheral nervous system is how we get, information from our external environment, and we have the impulses to do the things that we're trying to do. So motor nerves. And the autonomic nervous system is going to be involuntary motor functions, things that you don't need to put input in to get a response out of. Again, if this is going too fast, go back, rewatch, come back to where we are. Moving forward. The digestive system. This is where food and fluids travel through our body and is digested for use. This consists of the stomach, the large and small intestine, and then obviously all the mechanisms inside that break these things down so that we can use them at the cellular level. At the end of the day, that's really what we need to do. We need to break this down into its most simple parts. We need to break it into glucose, and we need to have water that's being moved in and out of the cells so that we can make sure that the cells are healthy. So the digestive system is, simple in the sense of, hey, this is how it all works, but it is more complex than just the stomach, small intestine, and large intestine, because we have accessory organs that assist with things like digestion, movement of food, breakdown of materials, and then of course the, not just the breakdown of foods, but the sorry guys, it's getting late. How we synthesize these things into usable products. So these accessory organs are the liver, the gallbladder, the pancreas, the spleen, and the appendix. And one thing I definitely just forgot to mention is that we can't just have these things synthesizing or assisting with digestion. We also have to have filters, and that's where we get into things like our liver. That's a fantastic example of one of the filters, one of the many filters in our body. Now, this is typically in class where I say all these organs that we're talking about, you need to know at least one major function of each organ. I will say that here now, and that just really applies for anybody that's watching these videos. If you don't know what the liver does, go look. It's super easy. If you don't know what the gallbladder does, go look. Same thing with the pancreas, the spleen, even the appendix. And before anyone goes, oh, Johnson, the appendix doesn't do anything. It's not that simple. It simply is not. You gotta look. All right. So accessory organs, you gotta know what they're there for. Don't slack. The integumentary system, aka your skin. The integumentary system is your skin. Now, your skin doesn't necessarily feel like it's this impenetrable wall, but really, your skin is one of the best protections that you have to getting sick, because it's not just there to look pretty so that you don't look like a horrendous horror movie where you're running around just, full of flesh and looking terrifying. It protects you because it is able to be a selective barrier. So it protects you as a selective barrier. It provides shock absorption. It helps with water balance. It regulates your temperature. It even helps excrete waste. And it's not just excreting waste through sweat. You can constantly be losing additional waste through your skin, and you would never even know it. We excrete stuff, small but still not insignificant amounts of CO2 through our skin and other waste products that our body simply doesn't need anymore. So if you've ever wondered, you know, it's not just as simple as sweat and stank. Your skin is doing an incredible job keeping you very well protected. Now the skin has multiple layers. We'll talk about those real quick. From the top to the bottom, we've got the epidermis, the dermis, and the subcutaneous layers. The epidermis is the outermost layer. That's where we have our skin. That's where we have the very first layer of tissue and adipose tissue or fat. And we have the majority of what we feel as these receptors, things that are going to give us input, or they're going to give us a signal from the outside world. Lower than that, we have the dermis. This is where we start to have larger blood vessels. We also have more intense layers of muscle and sometimes a mix of adipose tissue. And this is also where our roots for our skin follicles are. And then finally, the subcutaneous layer. This is where we have the big stuff. We have our veins and arteries. We also have a lot of adipose tissue, and it is by far the lowest level of all these. And you can see all that in this picture here. So you can kind of see what this is all broken down as. But again, if these are slides that you're struggling with, go back, rewatch, come try it again, and definitely look for those supplemental videos that are in Canvas. Going on to the endocrine system. The endocrine system is what produces and regulates hormones that your bodies need to function correctly and to be stimulated to function in a certain way. And our endocrine system is different between males and females, obviously, but it is responsible for, you know, really making sure that the body is stimulated enough to do what it needs to do. The primary organ for this is the pancreas, and it is expressed through the adrenal glands and other glands as well. Sorry. I apologize. It's starting to get late, so I'm getting a little sloppy. My apologies. But the adrenal glands secrete epinephrine. We have other glands that will secrete other hormones. We can talk about that real quick. So if you look here, let me get this just a little bit bigger. So we got the pineal gland, which is going to be, you know, helping basically regulate your sleep cycle, the circadian rhythm. Pituitary gland that's going to be regulating endocrine glands and helping with growth. The thyroid and parathyroid glands, which helps regulate your metabolism and your blood calcium levels. The thymus gland is really regulating the immune system. And then we have the sexual organs like the ovaries and testes in female and male individuals, respectively. The adrenal glands, which regulate water and electrolyte levels, as well as epinephrine, which is an aspect of our fight or flight response. And the pancreas, which regulates blood sugar levels. And this is a very, very basic breakdown of what we can expect to see from the endocrine system. But this is a very, very simple look. Moving forward, we have the renal system. The renal system is another one of those filters, just like the liver, and it is expressed as the urinary system. It helps us regulate fluid levels, it helps filter out chemicals, and helps us adjust our body's pH. And when you are looking at that, if you are familiar with pH, you're probably thinking, oh, we have that? Yeah, well, we have to find a nice balance between acidic and basic, because too far in any direction and we'll die. The primary organ of the renal system is the kidneys and the bladder, but we also have accessory organs or accessory parts, really, which would be the ureters and the urethra, as well as the excretory path of travel for our male and female individual human. And again, we can go ahead and we can blow this one up. This is another one from the book. Kidney filters blood, produces urine. The ureters take this from the kidneys and move it down towards the bladder. The bladder collects all of that. It's expressed as urine, and then it is moved from the urinary bladder through the urethra, and then it is excreted as urine. We can see those ureters and urethra as those accessory muscles. Ureters, again, transfer urine to the bladder from the kidneys, and the urethra excretes urine from the bladder to the external environment. All right. Finally, we're hitting the very end of our systems here. We've got the reproductive system. The male reproductive system is made up of the testes and the penis. And honestly, I think that I have students that are old enough to, understand how this works. So I'm not going to really spend any time with it. As well as the female reproductive system, which is expressed as the ovaries, the uterus, and the vagina. And again, I guarantee that every single person in my classes understands how these works. It'd be a little silly and kind of a waste of time to be going over these. I will say that in this class in EMT, we will actually have to spend a fair amount of time talking about the female reproductive system because we have an entire chapter on emergency childbirth and gynecological emergencies. So we will do a bit with that, but that's really more focused on very specific aspects of that system. So that'll be way, way, way further down the line in class. Cool. And here's another picture expressing those. But again, I feel like I know that most of you know this. And if there are any students that have any questions, I'm more than happy to point you in the right direction for that type of education. I certainly don't want to be a hindrance or a stopping block for you, but I feel like most of my students are capable of understanding how these all work. So again, we're going to be doing the chapter review real quick. We're clocking in just a little over 2 hours and 15 minutes here. So let's make sure that this is nice and tidy and all cleaned up. So as it says here, as an EMT, your knowledge of the anatomy or structure and functions or physiology of the body will be important in allowing you to assess your patient and communicate your findings accurately and efficiently to other EMS personnel and hospital staff. So from this review page, what I want you to know are two key terms: anatomy and physiology. Anatomy is body structure. Physiology is body function. Okay, and I'm going to put that in because for some reason that's not in here, and I think that is super important. Anatomy equals body structure. Physiology equals body function. If you don't know the key term there, anatomy and physiology, this is going to be a painful class. Make it happen. Make it happen, baby. All right. Through all that. Boom. The major body systems of which you should be familiar. We've already talked about these, so I'm not going to keep doing this. You can read it all there. Same. We just did all these, so it'd be silly to sit here and say all those again. Again, reviews like this tend to turn the student into a zombie. So I just want to make sure that we're hitting the slides so that we can say we did it, but you guys get the idea. Remember, cellular metabolism requires a constant supply of oxygen and glucose. Absence of either component disrupts normal metabolism. I'm going to go ahead and I'm going to add something there too. Annotate. Oxygen. I'm going to say and water. Cool. Cellular metabolism requires a constant supply of oxygen, glucose, and water. Absence of any of these components disrupts normal metabolism. Very, very important. Next, cardiopulmonary system combines the functions and respiratory and cardiovascular systems to provide oxygen at the cellular level. Y'all know this. Y'all know this. Shock occurs when the cardiopulmonary system fails and cells become hypoperfused. We talked about that. We've already done that. The body is composed primarily of water, and this fluid is distributed throughout the body systems. Where? How? Through the blood vessels, via the plasma. It's regulated through the lymphatic system, as well as other systems like the renal system, which is comprised of the kidneys. So very important that you understand. You gotta have water. Gotta have water. All right, we're not going to do questions to consider. I think that this video is long enough. I will leave this up for a moment, and I'll read it off to you in case you're just listening to this and driving. It says, when evaluating a patient with a cardiac problem, consider the impact on the respiratory system. When evaluating a patient with a respiratory system, consider the impact on the cardiovascular system. What impacts do problems in these systems have on each other? We talked a little bit about this. I want you to take a moment and consider oxygen in, waste out, got to pump it through the body. You guys pretty much should understand the reason why the respiratory and cardiac systems are so dependent on one another, and specifically why we look at it from that concept of pipes, pumps, and fluid. Next, question to consider. Shock must be recognized immediately. What's the pathophysiology of shock? The pathophysiology of shock is hypoperfusion. Hypoperfusion can come back to the pipe, pump, or fluid. So look at the heart, look at the lungs, look at the cardiovascular. Look at the blood vessels and the blood. Then we've got these the other slides. Critical thinking. You are treating a patient who was recently released from the intensive care unit with a massive infection, aka sepsis. This has impaired the patient's ability to regulate the size of the blood vessels. All right. So we didn't talk about sepsis, but yeah. One of the things that we need to consider, it says, how might this affect the patient's ability to compensate for additional illnesses? What steps should you take to help this patient compensate? One of the things that we will talk about further along in class is the concept of sepsis. Sepsis is something that, we understand infections, but sepsis is a generally still emerging concept. And it's this idea of the body becoming basically a repository for waste, but one that can't remove waste. So basically it's an overfilling trash can. So when we look at it from that perspective, and we understand that waste needs to be removed because it has no purpose in the body and it can become dangerous, we understand sort of how that starts to affect the body. And one of the most obvious aspects, or one of the most obvious side effects of a patient becoming septic is that the body loses its ability to change the diameter of the blood vessels. We didn't really get a chance to talk about that during this chapter, and this is why these chapters are structured a little strangely. We actually talk about that during pathophysiology in chapter 7. But our arteries have the ability to dilate or become larger and constrict or become smaller based on demand. And that demand is a complicated process that's kind of, originating itself from the brain and through the different systems that regulate vascular response. So sepsis tends to become an obstacle for that and tends to start to mess up the system so that they can't do that. And what ends up happening is that the blood vessels start to expand or dilate rapidly, which drops the blood pressure, and the whole system gets thrown out of whack. The heart has to work harder. The blood eventually may not be able to fill those really, really large vessels, and eventually the patient, may become so overburdened that they can no longer compensate, and the body starts to shut down, or they may go into decompensated shock and go into sudden cardiac or respiratory arrest. So the answer for these are going to be talked about in other chapters, but basically, what steps should we take? Well, we need to be able to recognize early. We need to supplement with oxygen. We need to also determine if the patient needs emergency or supplemental ventilation, so we may need to breathe for them. And at the end of the day, we need to rapidly transport them to the right hospital and let them know what our findings are, because if we aren't part of that process, we're not helping the patient, we're hurting them, and we aren't being a patient advocate. Woo! All right, so this is the last slide here that I'm going to go over. The rest of it is those appendix pages that you can find in these PowerPoints that you have online. But I'm going to go ahead and I'm going to stay right here while we close out. So we're just over 2.5 hours, or I'm sorry, 2 hours and 20 minutes. So I'll keep it brief and pretty. This chapter is critical. You must understand the concepts here. I can't supplement this in any other way for you. So you must understand this so that you can move forward and, learn with us, with the rest of the class. And without it, this class is not just going to be difficult, it's going to be impossible. So if there are any areas here that you don't understand, the time to ask is, the minute that you realize, hey, I don't understand this very well. Or you need to go out and look for those resources that help you understand them. The materials that you have at your disposal, the PowerPoint, the handout, this video, my normal classroom lectures when I'm back in the classroom, they are critical to being a complete picture. Without it, you just have a little bit of this, that, and the other. And a lot of students that don't really like using one or the other find that they need to supplement with something else. If you're using all those and you still don't understand, that's an excellent time to let me, the teacher, know, hey, Johnson, I'm kind of struggling with this. Or you can look before you come to me and try to find some materials on your own that help you understand these concepts. But overall, as a student, whether you're in a high school class, in my high school classes, or you're in one of my adult classes, the responsibility does come back to you, the student, to let me know when you need help. And letting me know that you need help at the end of the semester, at the end of the year, is too late. So the moment that you're just like, I'm lost, I'm confused, that's when you got to come to me. Cool. Thank you very much. I appreciate it. It's been a it's been just another day here at home with the little one and with my wife. Thank you so much for, again, being understanding of this time. It's a special time for us, and you know, I can say without a shadow of a doubt that I miss being in the classroom. But guys, I got to tell you, this little guy is amazing. I just love spending time with him, and I just really can't thank you all enough. So until I see you in class again, thank you very much. Keep learning, keep talking to me, and aside from that, we'll see you all very soon. Take it easy, be safe out there, and have a great one.